Thank you and good afternoon on this beautiful day. We actually lucked out. We heard that the room across the courtyard, they're getting water in the room. So be prepared if you have anything over in Venezia later. So we are going to talk to you about serving the traditionally underserved through population health improvements. So our plan is to review the business case for why we needed to be more heavily involved in population health management, discuss the importance of why we had to get all of our stakeholders in agreement in order to make this a successful launch. Andrew's going to go over the power of dynamic reporting with you and demonstrate what we built. I'm going to talk a little bit about some of the interventions we're working on, share our results to date, and answer as many questions as we can. So hopefully when you walk out of here today, you'll get at least 2 best practices to take home with you on launching cross-functional teams. Help recognize the importance of defining end-user requirements before you get too in-depth in the build. Identify how to utilize data to operationalize your organizational initiatives in a clinical care setting. And work on leveraging data to identify opportunities for maximizing our new favorite term, alternative payments. As you heard, we're from the University of Texas Medical Branch. That means we're headquartered in Galveston, Texas. Our system currently has 5 inpatient hospitals. One of those is a prison hospital. Over 80 clinics, over 800 providers, and more residents than I can count. But our mission is to improve the health of the people of Texas and around the world by offering innovative education and training, pursuing cutting-edge research, and providing the highest quality patient care. The short version, we work together to work wonders. If you're in Houston and you see our commercials, that's what they go with. And again, this is basically Southeast Houston is our catchment. Gulf Coast, Texas. The fun place. And it's raining there too today. Did you know 6 out of 10 adults in the US have at least one chronic disease, which is the leading driver of our $3.3 trillion in annual healthcare costs, and that number came from 2014 data, so we know that's gone up. 38.4% of adults will be diagnosed with at least one type of cancer at some point in their life. 1 in 3 have high blood pressure, and mine's going up standing here. And 30.3 million people have diabetes. That number is from 2015. So again, that's a lot of the population health we're talking about, because that one is very lifestyle focused, as is blood pressure. We're working on ways to help people control things if they know they're at risk, if they've already developed, so that their quality of life is better. I have told our Health Catalyst partners many times, my goal is to keep people out of the hospital, out of the emergency room. But you got to think about the money. So we're dealing with at-risk contracting, pay-for-performance agreements, all of that. You need data to react to, and you can't have something that's old. If you get a quarterly report, you're already 3 months behind, and then some, trying to adjust what you're doing. Some common population health challenges. Patient engagement. Everybody listens to everything their doctor says, right? Do you do it? Provider attribution. One thing we've noticed during this process, and Andrew's going to talk about it a little bit more, we have a primary care provider field that we don't trust. So we had to find another way to figure out who owned our patients. Because we're looking at federal and state level reporting, we needed to make this compliance proof. I get to be the audit queen of UTMB. Doesn't that sound fun? You have a 6th sense of the word fun, if that's what you think. And a recognition that it takes time. This is not a magic bullet. It's going to take time. It takes repetition. And as an academic medical center, we are constantly educating our providers as those residents come through, because the residents take care of a lot of the documentation, right? All right. We're a teeny tiny $3.3 billion operation annually. And almost 45% of our patient load are either Medicaid, Medicare dual eligible, or uninsured. Bill Gates could walk through with a big old stack of cash in his wallet and say, I want to pay. So I'd count him as uninsured. But typically it's the people who are working, hourly wage at the fast food place. They're not covered by their parents anymore. They can't afford to buy on the exchange. They're kind of gambling that they can make it by. And we're here to tell you that a lot of them are in trouble. We also, like I said, you heard me mention the prison hospital. UTMB has the contract to cover about 3/4 of the state of Texas for the Texas Department of Criminal Justice. And, oh, by the way, it's about to change to 6, but right now we've got 5 accountable care organization contracts, 2 of which overlap with what we're talking to you about today. You mentioned that you heard the word DSRIP. Who deals with an 1115 waiver or DSRIP? I'm sorry. So Texas went into effect in 2011, and then we got a second set of rules in 2016, which is what we're working under now, very outcome driven. Payments are tied to performance. For us, we have 30 different outcome measures. There's 32 rates. Dan Heinmiller, who's sitting in the second row here, is kind of shaking his head thinking about all of the things that they've had to build in the last year and a half for us to track all 32 rates. Medicaid and low-income uninsured, again, like I mentioned, these are the people that are traditionally underserved. They either don't have access or they have access and don't know how to use it. And that's been our charge, is to figure out how to get them to the right setting at the right time, the right cost. And that last bullet is our business case right there, because we have over $50 million at risk annually tied to DSRIP, 3/4 of which are tied to these clinical outcomes. Nothing like having an 8-figure at risk to get some attention from senior leadership. So when we were putting the slides together, we were trying to think of some of the things that would show what we were trying to improve, and easy to swallow pieces here. We were forced under the rules of DSRIP to pick that list of menu, so we wound up with the list of 32 rates to deal with. That was our bare minimum of things to follow. The Texas Department of Health and Human Services published this menu. Anybody from Texas here? DSRIP facility? It was written as, a lot of these measures were written as payer measures, so trying to adapt it to the healthcare setting was a little bit of fun, or a lot of fun, not so much. But what we wanted to do was look at that it's a portfolio. We've referred to it as a portfolio of measures often. It's an integrated set. What you're going to see is that we wanted to pick things that applied to our strategic mission already. So our measures are primary care focused. We want to keep people healthy. Previously, we would be using custom reports from our internal clinical data management. Probably get them monthly, maybe quarterly. If you wanted to make a change, you had to go through the report request process and wait 4 to 6 weeks to get a meeting. That type of responsiveness was not going to cut it with what we're trying to do here. We had to do an evaluation of what it would take to get there, so evaluate the lift. And we agreed, we convinced leadership that we needed more help than we had internally, because we needed real-time data. So again, 5 bundles: diabetes, heart disease, adult primary care, so that's a lot of adult immunization, chlamydia screens in young women, which is a fun topic to have. Yeah. Cancer screening and pediatric primary care. Wellness measures, things where, if you're familiar with the term ambulatory care sensitive conditions, it's all up in here. So we're our first poll question for you. So if you get your phone out, your app up and running, we want to know, of those up there, which has the most priority at your organization? Steve, how are we doing on that one?
The first question?
Yeah.
Let's see. All right, it should be up.
There we go.
Okay.
To the surprise of no one. That actually makes a lot of sense. Depending on which set of literature you look at, diabetes prevalence is anywhere between 8 and 15% of where you are. I myself are probably a prime candidate because while you guys were across the street eating lunch, I was eating chocolate. That was the snack I had in the room. Okay, thank you. We had to pick all of them. So, but if you look at it in this lovely graphic that took us a little while to make, it's a flower, it's pretty, it's a strategy though. You can't make a 5-circle Venn diagram easily. I tried. But it shows you that if you put all these things together, it's an integrated strategy to improve population health outcomes. We have individuals in our data that qualify for 15 or more of those measures. That's a lot, and a lot of them are what we not so affectionately refer to as train wrecks. We're trying to figure out how to make them less of train wrecks. But the big takeaway here was we had to get all of our stakeholders in agreement about the prioritization of this. You heard me mention the dollars. That was a big driving force for that got a lot of attention. Internal resources, we have people with really good ideas, really good skill sets, but we don't have enough of them. So waiver operations, that's us. Clinical operations, we had nursing, we had ambulatory leadership, we had physician leadership. We had our beta team to help understand the technical support. Our chief medical information officer, I want to put his picture in a frame because he's been our biggest champion and the one who will go to battle with us when people want to argue. Chief medical officers for both the health system and the academic enterprise. Those two gentlemen also very good at giving us strong support. Our decision support team. Clinical data management was still involved in this discussion because they need to know how to help support it going forward. Clinical EMR build team because, oh, by the way, in the middle of this, we're on Epic and we've had a couple upgrades during the build. Did you know things break during upgrades? And then our analytics provider partners. So I see Dan, I see Alan. I think, did Rob get in here? I see Jessica. So we've had really strong partnership with our Health Catalyst friends. And then we had a leadership oversight team who held our feet to the fire to make sure we did what we needed to do. Not only did we have to have the data, we had to be 100% compliance ready. State of Texas, under the rules of DSRIP, has to have a compliance review on just about everything. And it's a zero tolerance. If you're off by 1 in the numerator, you suddenly have a 6-month audit trying to get it all squared away. Ask me how I know. That was one of the biggest lessons learned from Waiver 1.0 was that we had a little trouble with replicability when we had to go pull audit data. This has solved that. But the big deal was this took time. We started the actual build for this in April of 2018. And we made sure that we had carve-out time for bi-weekly meetings. We had to think about attribution models, individual measure inclusion criteria. We have a spec book that's about yay big when you print it. Every measure, all 32 of them, had to be individually developed, validated, deployed, pulled back when we found something else, revalidated. It's been an iterative process. We had to account for variations in clinic workflows. And that attributed to a lot of the rework of finding out, oh, they do it differently over here. We need to go pick that up and adjust so it becomes an or statement. Developed an attribution model or models. You heard me say a few minutes ago, we don't trust our PCP field. We don't trust our PCP field. You know what the #1 PCP name in our data is? Andrew, you want to tell him?
Patient does not have a PCP.
Followed shortly by, oh, that resident isn't here anymore. It was not a reliable field. That's a separate quality initiative that we're trying to work on. So that's why one of our models had to be attributed billing provider. Who's the last primary care person that touched them? We needed a location field. Where did they last go? If we're trying to figure out where they might have the opportunity to set a patient-centered medical home. Build and reviewed the code. Lather, rinse, repeat. Alan, how many times did we rebuild things? A lot. and conduct extensive validation and chart review. Ladies and gentlemen, you are my witnesses. This gentleman behind me did somewhere in the neighborhood of 4,500 separate chart reviews to validate these measures.
Not alone.
I only did about 500, and we've had about another 500 elsewhere, but still, if you want to think about trying to do that in a 6-month period, that's a lot of work. Poll question number 2. Get your apps back out, and we want to ask to think about your own organization's readiness to build a sustainable, real-time data analysis tool to support a multi-million-dollar alternative payment program. That's kind of what I thought. It's scary, though, when they said, here, you've got the keys. Make sure we go get all this money. But think about all the people we just referenced that we brought into the umbrella for this. We had our stakeholders buy in beforehand. We did outreach to the various physicians who, at clinic level, to get them over the, oh, your data's wrong. That's not me. Yes, it is you. Here you go. Here's why. We can prove it. And now the fun part, ladies and gentlemen. Andrew's going to show you a demo.
Thank you, Susan. So Susan spent some time saying why UTMB needed an analytics application and kind of how we started. And I want to tell you what we ended up doing and how we got there. And so let me pull that up real quick. And by the way, whoever said they're extremely ready on that last poll question, I think there's some vendors here that want to talk to you. Okay, so we have our demo site up. So this has no PHI in it, no patient data. And when you first come to and this is built off of Health Catalyst Community Care application. And when you first come to our application, we have this splash page. And the one pertinent piece of information on the splash page is last reload. Now this says May 2nd because it's my demo site, it's my dummy site. But our site reloads every day around 10:30 in the morning or 11 in the morning. And so we have fresh data every day to work with. Okay, so our workflow in our application goes from left to right. We start with our Measures tab and we end with our Call List tab. So let me go ahead and click into my Measures tab. So like Susan said, we have 30 measures, 32 rates, and so you can see they're all here and they're all bundled by the different bundles, diabetes, heart disease, and so on. We have 2 different contexts. We have a current context and a historical context. The historical context takes snapshots of data from the past and then trends it over time. So we'll take a look at that here in a second. So what I want to do usually when I come here is I'm diving into a measure because I want to see maybe something we're not doing very good at and find what's going wrong with it. You can see that we have our achievement percentage here and then our targets, baselines, our measured rate, and then my favorite is this one right here, total opportunities, which takes your numerator minus take it out of your denominator, and that's the patients that you actually can go act on. And so that has been very pivotal when I go out and talk to physicians, and I'll talk about dynamic reporting here in a second, showing them how many people they could actually affect. So let me select one that we don't do historically well on, our adult immunizations. So adult immunizations, every adult 18 and older must have 5 different immunizations to be good, to the good in that numerator, or they need to be a certain age. So if you're under 65, you don't need a pneumonia shot, for example. So here I can come up here and, like Susan mentioned, the different attribution models that we created. I have here location, so I can see who's doing well, who's not doing so well. PCP, again, we don't trust this. Because it's bad data, to be honest with you. Specialty, attributed billing provider. Now this is where we've had the most success. So if I come in and I see patient X, provider X 5 times, but I claim provider Y as my PCP, we're going to go ahead and attribute, I'm going to go ahead and attribute myself over to the provider X because that's who I'm actually seeing. And so this has really cleaned up our data for our provider reports. So let me click over to our historical context, and quickly you can see that over time we've trended up on this measure, and this is just the first half of the year. I have much fresher data in my current application. In March, we found out that we were doing varicella titers on all pregnant women across our institution, and we never put that code into our report. And so that's what that little bump is right there. It was that was a code change. And so we have people that are diving in, and from the speaker this morning, going and finding problems. That's really what we're doing with this application, is going and finding those problems. Okay, so I selected a compound measure, so I actually can use my compound measure tab to come in, select different immunizations, and break them down by themselves. Now this is a demo, but what we've recently put in, on the top there on the right, we put in bar graphs that show each immunization and the percentage that we're doing for each immunization, so we can break it out, these large measures. I could tell you right now, I need to do better on flu, I need to do better on Tdap. If I attack those two immunizations within our institution, we will do much better on this measure, and that's what we've been doing, and we have seen some success. Our performance tab gives us a myriad of different items that we can look at, breaks the data down. One thing that we added was our MyChart enrollment, which is our patient portal. If we're going to do patient outreach and use our MyChart messages, we need to know how many people in this measure have access and are currently active on our MyChart portal. The provider tab allows me to dive deeper into that attributed billing provider and see who's doing what. I can look at location. It's just another way to look at this. This makes a great printout to take to a nursing leader meeting or something where I want to get them competitive and start competing against one another. Oh, well, you're at 30%, I'm only at 15%. So this is a great report to take out to your clinics. The patients tab takes us all the way down to the patient's level. So if I had a provider, I was filtered on a provider and diabetes, and that provider had 30 diabetic patients, I could come in here and start looking at the patients and start seeing if I can tell the story of why that provider has these certain patients missing these certain things. The Today tab is a schedule for providers. Providers can come in, look at their schedule, see who's missing what for that day. So our providers enjoy that. And then last but definitely not least, this is the tab where all of our interventions kick off. So this is where I can come in, select my dynamic reporting, select my columns over here. I can send these out to my locations, out to my providers, leaders. And this is where we start to inform our interventions. And so patient outreach, pre-visit planning, some of those items as well. So let me go ahead and switch back to the slides. Okay, so kind of a recap of what I just talked about, those custom reports that I can pull out and send across our institution, across our clinics, has really helped. Our compound measure stratification that I just mentioned. That third one, though, the proactive versus reactive. I have daily refresh data at my fingertips. In the past, and I think Susan mentioned this, it had taken anywhere from 2 weeks to 6 weeks to get a report from our clinical data management department. And that would be, they might send it to us and then, oh, well, that's not exactly what I was asking for, and send it back, and then they work on that. By the time that provider might have already come in. And so, and we might have missed an opportunity. And so we're able now to be proactive in our approach, and that has really paid large dividends. And then what I showed you, that trend the data over time. I can take a trend line, and I've been doing this quite recently because we get paid on the calendar year, so December's the end of it for us. And so I'm starting to trend to the end of December and saying, we're just not going to cut it on this one. I mean, we're improving, we're doing great, but you know what, we need to do better. And so it's really been useful to be able to do that. We're very happy with the visualizations. We see that for someone like me that's red-green colorblind, it could be difficult, but our providers have given us great feedback that they can come in, they can look at how they're doing versus someone else. A couple of stories here. We saw that in our RMCHP clinics, so regional maternal and child health program clinics, that we were not up to standard on primary diabetic care, primary care for diabetes. And so we instituted some changes there. And we saw, and I'll show you a graph of this here in a second, of that increasing quite a lot. We also identified gaps in breast cancer screening. The nurses and the MAs at our clinics were scanning in external results into the external results scan section, but we're never updating the health maintenance section of our Epic EHR. So that was a quick find. We said, you guys are at 60, 70%, but they said, no, we're not. We're at 85, 90. And so that disparity, that discussion led to that. And then here, it really has allowed us to pull a report. Instead of pull a report of A1C tests that are missing, we're now pulling reports of patients and everything that they are missing. So it's really a different way of looking at the data. So I can say, these patients are missing all of these things. Let's tackle those. At UTMB, we have two areas or two ways of influencing or providing interventions at our institution. We have decentralized and centralized. Decentralized is when I feed a clinic and I tell them we need to do better workflows, we need to do this, we're going to help you in this way. So that's when I go out to where the patient care is happening. Then we have centralized, and that's something that Susan and I are spearheading right now. We have two teams, a wellness team that's doing pre-visit planning and an outreach team that's reaching out to the patient. So the wellness team is getting the provider ready for that visit. They're putting notes into the schedule, into the appointment notes. And they're also going out to our HIE, our local immunization bank, some of those items, external data sources, and updating the chart. And so the patients had a call from our outreach team. They're ready. The provider has extra notes that are done from a human hand that are not automated, and he's ready. And so when those two come together, we're getting much more of an uptake on what we're asking everyone to do. We're really excited about our calendar year 2018 data. 85.4% of dollars came into our institution that we were gunning for. That was $2.5 million over projections, and we can point straight back to this application that helped us get that. 100% achievement on 23 out of 32 measures, and the other 9, a lot of them had partial achievement. But Susan said this, we're ready for an audit, we're ready for compliance review, and we can't put a dollar amount on that because if you've ever had to pay dollars back to a state agency because of something you did wrong or an oversight, that's painful. And so that's where those 4,000 chart reviews will come in handy later. A couple of stories here. Chlamydia screening. We saw that we were not going to hit it. We trended it over time. This was in 2018. We were able to pull reports out of our application of who's coming in. They're already scheduled. Send it to each clinic leader. And right here is where we found that our report, that we weren't going to hit it. And look at that. Now this is December right here. And so you can see our labs trickled in over time. So we were holding our breath there. But we hit the target based on screenings that were initiated within the calendar year. The data within our application told us that something was wrong with, we were prescribing antibiotics for the wrong types of earaches, wrong types of sore throats. So we went, took a couple of best practice flyers to only 3 of our clinics, had a discussion about this is really the way we should be coding. This was a coding change. This went up, went to the other clinics, and now we're great this year. We're flying high on this measure. This is an example of what I said earlier. See this little elbow right here? That little elbow was about the time that we talked to our regional maternal care clinics and told them that we need to do more foot exams. They didn't even have the little filament to do it. So there was many different barriers that we had to overcome just to get that going. And then this is an example of an automation, what an automation can do in your EHR. A process measure can be automated. This is counseling for pediatrics. The rule is every year a pediatric should be counseled. So if they come in and they qualify, we went ahead and automated that something is going to be printed, it's going to be handed to mom, or it's going to be a little blurb on the after visit summary. And so we automated it and it skyrocketed. And I think we're up in the 90% now and going forward very well. Okay, so just wrapping up here, some key lessons and recommendations. Like Susan said, include as many stakeholders as possible at the beginning of your journey. Susan and I, we only knew what the state wanted from UTMB. So we were look at the measures and interpret it for Health Catalyst and our internal partners at UTMB. We understand that each organization has unique analytics and reporting needs. Susan and I were just at a statewide learning collaborative last week where all district providers across Texas got together. And I heard 2 different stories from other academic medical centers within Texas that built all of this into Epic. They were very excited that, when they saw that a district registry patient was in their workflow, they could go ahead and clinically affect that patient. And that's good, and there's some good sides to that. But we have better analytical capabilities. They still have to pull that raw data out and that registry and do all of those just like I'm getting a report from our clinical data management department. And also, we're audit ready on a level that I suspect they are not. But there's good to have it in your EHR, but then there's also other highlights to not. You cannot manage what you cannot measure. I'm just going to let that one stand. And then value-based care is the new norm. Real-time analytics are required for success. We at UTMB see DSRIP, ACO, some of the items that we're being asked to do by the state and ultimately by CMS as our current value-based programs. And going forward, we only believe that this is going to grow. And so we believe that the real-time analytics that we've built now for these items is going to sustain us going forward and help us grow going forward and know how to tackle those challenges as we move forward in healthcare. And so with that, take any questions.
One thing I wanted to mention off the demo that I'm not sure you all caught, one of the things in that call list feature for us that's very important is language preference. So that's another piece of, as we're looking at having our outreach team figure out who does not have English listed as their primary, because that's going to influence the way we try and reach out to them as well. And that's another piece of the lesson learned, because we had feedback from our patient services, which is going to then tie into Prescini. So trying to hit all of the buckets on the balanced scorecard. Do we have any questions?
I've got a whole list here.
Excellent.
Shall I just read them and you can?
We've got a few minutes. We'll take whatever
let's
we
see
can.
if we can get as many as possible in. I'm sorry, Cynthia.
Someone's raising their hand. I was just going to mention that they could ask their question
In the application. Okay, yeah, type it in and then it will come up here, or like one of the questions that has already been asked if it's similar.
And if we run out of time, Andrew and I will be out in the hall afterwards.
Okay, what is the patient outreach team specifically doing to prepare the patient for a visit? That was intriguing to me as well.
And that's the team that reports to me. So they're doing a few different things. What we're doing is kind of looking at that call list of opportunities and reaching out to the patient directly, especially if they're not currently scheduled. Trying to get them to come in. Build that relationship, kind of find out, why did you no-show the last one? I see you haven't been in for you were in for a couple of sick visits, but not a wellness visit. Can we get you scheduled? We've couched that initial conversation actually off of that adult vaccination list. We're calling today to update your records. Make sure we have the most current information. Have you had this? Have you had that? And that's a good icebreaker with the patient. Now, we laugh a little bit. My team will tell me, this one, great, super excited. We got him scheduled in the next day for a wellness visit at one of the clinics. Not bad. Another one, slammed the phone down on him. Like, okay, they're not all great. We're not trying to get perfect. We're just trying to get better. All of these baselines were our 2017 data, and the state of Texas gave us some very interesting algebra to come up with the targets for 2018, 19, and soon to be approved our numbers for 20 and 21. But everything is trying to do better than you started out with. What else?
How many different payers are you working with, and are you getting claims data for your dashboard?
I can't count that high. Because we are looking primarily for the interventions we're working on, we're picking up the Medicaid MCOs for payers. But other than that, we've got county contracts, we've got self-pay. We can pull in the commercial data. What you didn't see in the demo is we could click the filter, and then here would come all our commercial patients. So the answer is every payer that we deal with.
And our application is EHR driven. And so there's another team called the ACO team that we work hand in hand with, that is working with our MCO partners and doing those claim-based work as well. But ours is mainly EHR-based data.
In our specifications for the build for this, most of the language goes, if you're using EMR data, if you're using claims data, but claims data is old. It's inherently old because by the time it cycles back to you, it's 60 to 120 days old. We needed something more responsive than that.
Do you use social determinants of health data? And if you do, how do you tie that into your?
So one of the nice things, and actually the meeting we were at last week, they said we can't use social determinants anymore. They're now non-health drivers. I guess the word determinant didn't set well with somebody. My outreach team, I have a social worker, which is awesome. She's only been there about 6 weeks, so we're still getting a handle on the panel. So right now, and she texted me this morning to say she's almost through our diabetes ER high volume list, trying to figure out who can we actually make a difference on and who are we really never going to reach based off the information we have. On that list, and she was looking at someone that through the end of August had 57 ED visits in this calendar year. They're using the ED for dialysis. This gentleman is Spanish speaking, he's undocumented, so he's not eligible for a lot of the programs, but he's still coming in routinely. We've got another individual, I think she said 30 years old, Spanish speaking. They see her almost every day. It's almost a social thing, because we can see through our access to Greater Houston Health Connect, our local HIE, not only is she a high utilizer for us, she's a high utilizer for another system. It's this type of thing we're trying to figure out for those individuals, what can we do to re-educate them on how to appropriately use the resources?
And from a data perspective, we do not have the ICD-10 codes for social determinants of health, and they're not flowing into this application.
But we have been talking about, is there a way to start capturing those
Right.
as a next step?
What was the most difficult measure to tackle?
I actually demoed it. So the
Okay, good.
the adult immunization record, you saw the worst data that's in there. I could have shown you foot exams or something, fun that we are green on and have been. But it's very difficult to get what we say, males that are born after 1980 to come in and tell us if they've ever had chicken pox. It's difficult to just get adults in general to get that primary care.
And
We'd like to think of others first, I guess.
Yeah, I mean, when you look at that, in that 5-part, it's the pneumonia vaccine if you're 65 and older, so if you're under 65, you're assumed good. It's the completion of the shingles series if you're 60 or over, and we all know there's a shortage of Shingrix. An annual calendar year flu shot, not to be confused with our flu season flu shot measure, so there's got a little bit of a timing issue. The varicella piece, and Andrew just hit it, that it's our big deficit there are males 18 to 39 who have not documented that they had chickenpox history, immunity, got the shot, whatever. And then the every 10 years Tdap, and I get mine in about 2 weeks.
When you were starting this work, who was on the work group? What were who were the players?
All right, we tried to make this a very open, come to the table, speak now or forever hold your peace type thing. Andrew and I one or both of us have been at every single meeting. So we're the subject matter experts for the specifications. We had, unfortunately, she just moved to Minnesota. We had a very engaged clinical medical director, internal medicine, who liked to be doing chart reviews at 2 o'clock in the morning and looking for workflows we hadn't thought of. We had our internal clinical data management team because we wanted to keep them engaged and aware. Again, we weren't trying to replace them, we were trying to augment what they could do. Just they're spread so thin on every other issue going on. We had our beta team of how to make sure that the application would work, ad hoc for various physician and clinical nursing experts, ambulatory operations to think about some of the things related to workflow, access, all of that. Especially when we started saying, hey, we need to pull in scheduling. Are they scheduled for a next something or other? Thinking about workflow, thinking about capacity. As we're working on our outreach, I can have my team call and schedule 1,000 things, but if we only have capacity for 100, guess who they're going to yell at?
Fitting the fitting the clinician activities into the workflow. How did you do that? And I think you sort of answered that.
So there's the work group that Susan's talking about was to build the app. We have another work group called the Population Work Group, I know. And that's where we have our CMIO and a clinical representative from geriatrics, internal medicine, family medicine, and they all sit down, and guess who's always on Skype or sitting at the end of the table? Our Epic Build team. And so as they say what they need, they turn to me and ask me what I need, what do the specs want, then we can both turn to the Epic Build team and say, this is probably what we need to put into the workflow.
So this becomes an enhanced prioritization of customization for Epic.
So speaking of Epic, why did you use an external application instead of Epic's Healthy Planet?
Compliance readiness.
Okay.
Seriously. Well, you know, we upgraded to Epic 2018 in June, and then we're starting the cycle. I got an email this morning that we've got a partial upgrade coming on the 21st. We weren't ready with the Healthy Planet stuff when we started this a year and a half ago. And again, we got burned badly in Waiver 1.0 on compliance audits for not being able to replicate. So there was that extreme concern that if we built it in there, and we've all seen retroactive payer changes, backdated notes, things that would cause the data to shift. We needed something, say, at a point in time when we pulled it, this is what it said, and be able to pull it all out and stand behind it.
And I'll add to that, because DSRIP is so stringent in the measures and what we have to follow, this has really helped us. And it's really just building on what Susan just said. It was the structure that we were trying to follow really made us move in this direction.
Texas has about 300 DSRIP providers. I would argue that Andrew and I are more ready than any other provider in the state for an audit.
That's awesome. Do you incentivize your providers based on measures? And if so, how do you handle pushback where many patients see next available physician? They are laughing. And,
well,
and they have no
there's a
PCPs.
two-part. There's a
So
two-part thing.
attribution probably could play into this question.
It can. I mean, we've had a lot of conversations with physicians who come back and say, that's not me. Like, oh, wait, when you go back and look at the notes, it's attributed to you because you signed the note for the resident that saw them. Oh, okay. A little bit of that. But this has led to some of those other conversations about why our PCP field needs so much more work. Incentivizing, I'm going to take part of that one. We've done a lot of clinic roadshows, and the last series, it was lunch and learns. The physicians were invited, the nurse practitioners were invited, but we didn't necessarily always get a lot of them. You know who we got? The medical assistants and the nurses, the frontline staff. So it was lunch. We tacoed about population health, and we've delivered so many tacos in the last 6 weeks. But it was a way to, you know it's healthcare. If you give food, people show up for meetings. But it was a chance to show them at their location level, at their clinic level, who are their patients. I got the chance to go to the regional maternal clinic in Beaumont, which has 3 providers and staff. Like, really? We're shallowing on cervical screens? No way. Let me show you. And here comes the list. And, oh, this person's going to come in a month. Can you make sure you get that done? This person's not scheduled. Okay, yeah, we need to call her and get her in. Okay, that's what you need. It's that aha moment of maybe I didn't get all this done that I thought I did. The foot exams one is a little different. We have providers that, I did it. It's in my note in a free text field. Nothing that we could easily find. We didn't go the natural language processing route yet. So it's buried somewhere. We can't find it. For the wellness team, as they're doing these pre-visit planning notes, you know what we have in there if they need a diabetic foot exam? The dot phrase. Use this documentation. And we're happy.
And I would add that we have a wall of fame on our population health website, and then we send out quarterly reports that can, some friendly competition every quarter is sent out. And so that's probably the most fun.
But what we've done is we've been able to develop some tools to give to providers. There's some provider level education that now is part of their annual requirement, specifically to population health. There's a monthly newsletter that goes out of tips and tricks. Go figure, October is going to be breast cancer awareness. Go figure. But
We have time for probably 2 more
Okay.
questions. So for the patient count of opportunities available, did you focus on working with the highest counts first, reaching more people, or the lowest counts first, since it would be easier to get a win with a smaller group? How did you choose that? That would be interesting to know.
as we were coming down to the wire last year, it was the where were we close? Where's the lowest hanging fruit? Where's the short piece to go? The long-term strategy were the ones where we were badly in the weeds. We have, it's not an either or. We're trying to eat the whole elephant, God help us. But that's where we're at with it. Some of the measures, though, because we're trying to go up against a national benchmark, it's hard. Some of these national benchmarks are based off of all-payer data. The well-child visits for children by the age of 15 months, we're never going to see that number because we lose too many of our kids once their moms graduate out of our regional maternal program when they lose their Medicaid coverage. The kid has 1 or 2 visits with us and then they go back to their local provider. Lost opportunity.
And we get paid on Medicaid and low-income uninsured, so I know which clinics most of those patients go to. And so it's a hard sell when I go there and they're at 85%, 80% on a measure, but they're seeing so many Medicaid and LIU patients that their opportunity number is bigger than anyone else's, even though they're knocking it out of the park. So how big the denominator is also important, and it can be a hard sell when they're already knocking it out of the park.
But it also makes it to say, thank you for doing so great. Can I get 50 more out of you? If we can kind of conceptualize it in that, it gets a little easier.
What level is your scoring calculated at? Is it aggregated? Is it per provider, per practice?
Yes?
All of
We
them?
can pull it, we have the capability to pull it in all fashions.
Okay.
I have a request. We were asked to prove we had a full house. My team didn't believe me. Remember, you heard that this was sold out, so y'all made us really happy here. Smile. Thank you. We appreciate your time and attention today. This is the way it's going. This is Value-Based Care 101 now. It's outcome-driven. It's very specific. And what you're starting to surface is that we're finding our high utilizers and having to find new ways to reach out to them so that we can build the relationship and get them in the appropriate setting. Thank you.
Susan, I asked her about cards, and she said she didn't bring,
Oh,
or she should have brought 150 of them. I think you will all want both their cards. This has been a wonderful session. It's given us some
And this-
nuts and bolts kind
There
of
we go.
ideas.
And we did say that when they release the slides to the site, they will be there with our contact information. I think we both see this in our sleep, so we're happy to share the joy and the pain. Dan's proud of us. Actually, Dan, Alan, can you guys stand up for a second? I want to thank you both, and if Rob's in here and snuck in, this is hard work. We were fortunate in that the team that we got to build, they were passionate and just as deranged as we are. This is a lifestyle. The data geeks are us. This is us. But look at what we can do. We can go to the various providers and say, I see the 100 patients on your panel that we're asking you to try and help. Can you get 10 of them? We're not trying to clear the whole list. Can you get some of them? That makes that conversation a whole lot easier to handle. Thank you.
Thank you very much.